Welcome everybody. Thank you for joining Aspire for today's webinar. Aspire stands for Alliance to Solve PANDAS and Immune-Related Encephalopathies. We aim to improve the lives of those affected by this devastating but treatable disorder. At Aspire, we have focused our efforts on programs that reach 5 core audiences that increase awareness and understanding while providing critical support to all members of our community. We increase awareness and education via our website, webinars, and toolkits. We support families via our Facebook group, one-on-one emails, chit-chat groups, and our provider directory. We educate schools via professional development in-service lectures so they can appropriately support their students. We help improve public policy by providing local advocates with advocacy tools and support. We support providers and researchers by hosting grand rounds, lunch and learns throughout the year, and other specific needs. Please consider supporting Aspire so we can continue our educational and support programs like today's webinar. So today we have Dr. AKinderlehrer. He's going to speak on microbes and mental illness, along with tick-borne infections and PANS and PANDAS. So he is a nationally recognized physician. I'm sure many of you have read his book, and if you haven't, I highly suggest you order it today, get it in your house, and start reading it because it's a really fantastic book. It's called Recovery from Lyme Disease, the Integrative Medicine Guide to Diagnosis and Treatment to Tick-Borne Illness. And we've given it out to many people along the way. So his focus for his practice is in the fields of nutrition, allergy, and environmental medicine, Lyme disease, and healing the whole body, the mind, body, spirit as a unified whole. He founded the New England Center of Holistic Medicine in Newbury, Massachusetts, but now currently has his own private practice in Colorado. He's taught extensively throughout the years, including practitioner training courses at the Omega Institute, the National Institute of Behavioral Medicine, the American Academy of Environmental Medicine, and of course, iLabs. Every year at iLabs, he presents his Lyme Fundamentals course. And like I said, he's currently practicing in Denver. So I really am excited to have him here today. Thankful for one of our families that we work with and support, and worked on a couple projects for connecting us to make sure that this happened. So I'm very thankful for them. And without further ado, I'm going to stop sharing my screen so that he can share his, and we will get going and start learning. Thank you.
Okay. Welcome, folks. And thank you, Gabriella. I just found out that Aspire is in fact an acronym. I had no idea. It's a great name for your organization. Today, as you know, we're going to be talking about tick-borne infections and PANS. And as you folks know better than anyone, this is a huge, huge deal. So let's start off with just Lyme disease. Is it a big problem? Well, glad you asked. Yes, it is a really big problem. And let me explain how much bigger it is than you hear. The CDC now reports 500,000 new cases of Lyme disease a year. However, of those 500,000, those are cases that meet the CDC surveillance criteria. And these criteria are really restrictive. Studies have shown in my clinical experiences demonstrated that those surveillance criteria will probably diagnose maybe 1 in 4 or 5 patients who diagnostically have acute Lyme disease. In other words, of those 500,000, you're going to have to multiply it by 4 or 5 to get the true number of acute Lyme diseases. This is recent onset Lyme diseases. And what do you end up? Like 2 million new cases of acute Lyme disease a year. Okay. Out of those 2 million, it is now well accepted that at least 10 to 20% of these acute cases become chronically ill. You and I call it chronic Lyme. They have other designations for it, but in some studies, by the way, it's not 10 or 20%, it's up to 50%. And that means, let's say 10% of 2 million, we're talking easily 200,000, right? 200,000 new cases of chronic Lyme, chronic illness. Okay. Now, these are now designated by the so-called powers to be as post-treatment Lyme disease syndrome, a designation that doctors like myself abhor, because it suggests that Lyme is no longer an issue. This is something else. And doctors like myself, no, Lyme is still an issue, and it's not the only issue. They all have co-infections and they all have chronic inflammation. But these people who go from acute Lyme to chronic illness and are recognized as such, that does not include an unknown but really huge number of people with Lyme disease never diagnosed with an acute illness, never diagnosed with acute Lyme. They never saw a tick bite. They never saw a bullseye rash. They may or may not have had a viral-like syndrome. They just went on to develop a chronic illness. And I can tell you that that's 4 or 5 times as large as the previous group. Take 4 or 5 times of the 200,000 number. We're talking a million new cases of chronic illness a year. This is an epidemic hiding in plain sight. The states most endemic are also the ones with the most moisture. That would include the Northeast, the Southeast, the Great Lakes, the Northwest. However, Lyme disease is now reported in all 50 states. But if I had to choose, I'd live in the Southwest, and New Mexico would be my favorite. Okay, so what's this designation I'm talking about, Lyme disease complex? Once it reaches a chronic stage, we're talking about more than Lyme. We're talking about, yes, infection with a specific Borrelia species, Borrelia burgdorferi, that's the Lyme pathogen, but we're also talking about co-infections. I do not see patients who don't have co-infections. I haven't had one walk in my office in years, and this is even with acute Lyme. They all have co-infections. And here they are, you've heard of them: Babesia, Bartonella, tick-borne relapsing fever, anaplasma, rickettsia, Powassan virus. And people think, well, co-infections, these are sort of like side gigs. No, Babesia and Bartonella in particular result in more serious illness and specifically more neuropsychiatric issues and are more difficult to treat than just Lyme disease. Basically, they make this whole problem dramatically worse. The downstream issues of this chronic infection result in dysregulation of the neuroendocrine immune system. So, you know, Western medicine separates those out: neurological system, endocrine, immune system. They're not 3 different systems. It's all working together in terms of regulating our body. We'll come back to that. The most common manifestations of Lyme disease complex are musculoskeletal and neurological. Okay. So how do these infections make people sick? Well, if it's an acute infection, that's local invasion of the skin. It stimulates an immune response, and hopefully, if treated early and adequately, the infection can be eradicated. However, eradication is not likely with a short course of antibiotics when multiple microbes are involved. I also mentioned there are studies that have shown even when the infection appears limited to the skin, we can find some of these microbes in the bloodstream. Chronic persistent infection, okay, now these bugs have taken hold. They've been with us for a while. We're not talking about local invasion. We're talking about dysregulation, and specifically dysregulation of our regulatory systems, nervous, immune, endocrine function. Like I said, it's really all one system, resulting in systemic inflammation, which causes what? Pain, autoimmune syndromes, and immune suppression. So our immune system's totally dysregulated. We have a lot of inflammation that's targeting our own tissues, and our immune system's not competent in fighting outside bugs. Basically, these infections in their chronic stage target software, not hardware. It's dysregulation of these regulatory systems, or disruption, yeah. So let's focus on mental health disorders caused by infections. How big a problem? A really, really big problem. Glad you asked. Okay. So here's psychiatric conditions associated with Lyme disease complex. And so the top three clearly are anxiety, often with agitation and panic attacks, depression, which could be suicidal, and then irritability, anger, oppositional behavior in children, rage. That would be the top three, but the others are not that uncommon. OCD, phobias, schizoaffective disorder. That's like some combination of schizophrenia and bipolar. Bipolar disorder, eating disorders, we'll be talking more about alcohol abuse, drug abuse, addictions, anhedonia. It's a fancy word for inability to feel joy. Dissociative episodes. This is really common. I'm amazed at how many of my patients offer this up as I feel like I'm just not there. Schizophrenia, other forms of psychosis, personality disorders, and suicide. Very sad statistic is the most common cause of death in people with Lyme, excuse me, is suicide. Okay, so we're going to start talking about some cases. So obviously, I've changed the names, but I've named this person after myself, Danielle. So she grew up in upstate New York, right? We all know that's one count against her, right? She did have multiple tick bites. No one ever saw any sequela that like, oh, she got sick after this. But at 2 years old, she started unaccountable screaming and trichotillomania. I never heard of that word either until I started writing up this case. Trichotillomania is hair pulling, but I don't mean just hair pulling. I mean pulling hair out. 4 years old, she had social anxiety. And as she got older, that became generalized. She became quite irritable. 12 years old, she's starting to complain of physical symptoms, fatigue, sore throat, cervical nodes, which are swollen glands in the neck. 14, she has yet another tick attachment. This time she has a rash. It's just a very small rash. They didn't think much of it. It was 2 centimeters or less. But things continued to worsen. Increasing fatigue, impaired cognition, postural lightheadedness, fancy way of saying you stand up, you feel lightheaded, sleep problems, and in particular, increasing anxiety, depression, and irritability. 15 years old, she begins food restriction and purging. She's admitted to an eating disorder unit with suicidal thought with intent. And at that point, she's diagnosed with anorexia nervosa. She's tried on a couple SSRIs like Zoloft and Prozac. They just make her more suicidal. They stop those and try Abilify. That has some benefit. She is discharged to outpatient clinic, but she's still refusing to eat. So they put in a nasogastric tube that she's getting all of her sustenance through this NG tube. She goes in and out of inpatient to outpatient to inpatient, outpatient. She does that 5 times. She continues to have suicidal thought with intent. At this point, the doctors told the mother that they really didn't know what else to do for her. She basically was continuing to refuse any oral intake despite intensive inpatient, outpatient psychotherapy, psychotropic medication, and behavioral interventions. The doctors actually said, well, maybe if she has a near-death experience, she'll choose life. I mean, that was their suggestion, which obviously was very disconcerting to the mom. Well, the mom is an RN. She's was pretty savvy. She said, we lived in upstate New York. Maybe tick-borne infections are doing something here. And she gets her tested for Lyme and brings her to my office because the test was positive. Okay, on physical exam, she really looked okay. She had a nasogastric tube in. She had not lost much weight, because she was getting those calories. The only abnormalities on physical exam was, again, POTS, postural orthostatic tachycardia syndrome. This is a manifestation of the autonomic nervous system being off, dysautonomia, stand up, pulse races, get lightheaded. And she also had Bartonella stria. What are they? Okay, so these are lines on the skin that can look like stretch marks. They are not stretch marks. They are in a different level of the dermis. They are actually caused by neovascularization. There's actually new blood vessel formation there. And if you biopsy them, you can actually find the bugs. Now, here's the irony of this particular case. This young woman saw these Bartonella stria. She assumed they were stretch marks and was more motivation to lose weight and not eat. So Danielle had a positive Lyme Western blot. She had positive Babesia. She had positive Mycoplasma. She was Bartonella negative, and I want to emphasize this. She absolutely had Bartonella. These stria are virtually pathognomonic. They're diagnostic of Bartonella. But the test, the antibody tests, the DNA tests, and so on, they just are not that sensitive. And I would say most of the patients that I treat for Bartonella, I diagnose clinically, not on the basis of the blood tests. So we treated her with antibiotics for a year, including 3 months of intravenous antibiotics. And she's had total remission of her eating disorder sustained for 5 years. So that was a real win. And here, this was written up, if you want to check it out. It's gotten a lot of good attention and indirectly has to do with why I'm lecturing to you today. But I want to point out that there's actually extensive literature, which I detail in this article, linking infections with eating disorders and with anorexia nervosa in particular. You know, it wasn't that hard for me to find all that in the literature, and I detail it in this article. So think about that. We're talking about infection, eating disorder. We're talking about autoimmune neuroinflammation, okay? Obviously a big theme here today. So how does that work? What happens when microbes trigger antibodies that cross the blood-brain barrier and attack the brain? Neuroinflammation, this is like brain on fire stuff, right? It results in mood, behavior, and thought disorders, impaired cognition, and movement disorders. What do I mean by movement disorders? Well, some of it is tics, like grimacing and, you know, weird movements, but also involuntary movements, which the medical term is chorea, C-H-O-R-E-A. Think of Huntington's chorea, but basically, you know, suddenly, you know, you're moving your limbs, and these are associated with the same type of neuroinflammation as PANDAS. Okay, PANDAS. PANDAS, as I suspect all of you know, stands for Pediatric Autoimmune Neuropsychiatric Disease associated with streptococcal infection. Not streptococcal disease, streptococcal infection. Sorry about that. It was initially described by Susan Sweeto, who did great work. She described it in 1994, and then it had a series of 50 patients in 1996. And she described kids who are perfectly normal. And suddenly, they after having a strep throat, they fell off a cliff. And the most common observation at that point was they had OCD, obsessive compulsive disorder, just out of the blue. Okay. Turns out that it's not only strep that can generate this problem. And in that 2013 conference, renamed it PANS. I shouldn't say renamed it. I would say they broadened the syndrome, because multiple microbes can trigger this, not just strep. So pediatric acute onset neuropsychiatric syndrome is the diagnostic nomenclature. It recognizes multiple microbes have the capacity to trigger autoimmune brain inflammation, also known as autoimmune encephalitis. And here are microbes that have been demonstrated to do this. Please note that there are a bunch of viruses: herpes simplex, influenza, varicella zoster, which is both chickenpox and shingles, Epstein-Barr, HIV, the common cold, and then I look at bottom right, SARS-CoV-2 causes a lot of autoimmune problems and can also trigger a PANS-like syndrome. And then there's sinusitis, mold, strep, of course, but Mycoplasma and Bartonella, these are common tick-borne infections. Okay, so I want to talk nomenclature here, you know, language, autoimmune encephalitis versus PANS. So autoimmune encephalitis refers to autoimmune inflammation attacking the brain. It doesn't say what's the cause of this inflammation. It doesn't restrict it to method of onset or to age group. It's just a broad description of their body's immune system is attacking structures within our central nervous system, within our brain. Okay, PANS then is a subset of autoimmune encephalitis. And there's case definition criteria, again, that were developed in 2013. So by definition, PANS describes a child or adolescent with the abrupt onset, the just, falling off a cliff type onset of OCD and or an eating restriction in a child or adolescent with no known neurologic disorder to account for symptoms, such as maybe a seizure disorder or getting whomped in the head. In addition to the OCD and or eating restriction, they need at least two of the following: anxiety, often with panic attacks and agitation, mood swings or depression, irritability, aggression, rage, behavioral developmental regression. And remember, these are often children, and their development goes backwards. Deterioration in school performance. So this is cognitive problems. Motor or sensory abnormalities. I referred to choreiform movements, the involuntary movements and tics, somatic signs and symptoms like bedwetting and pain syndromes. Okay, I can tell you that most of my patients have 3 or 4 of these subsets, okay? So that's the definition of PANS. Aha. So this is a slide that I took from a presentation by Susan Sweeto. And I did fax her and ask her for permission. I never heard back, but I'm hoping she won't mind with proper attribution. I love this slide. Maybe I think it's got beautiful colors, but wow, what a good way of displaying all the different ways that PANS and PANDAS-like syndromes can manifest. Starting at 12 o'clock, OCD, and moving clockwise, behavioral regression, severe separation anxiety, urinary frequency, handwriting deterioration, sleep disorders, psychotic symptoms, terror-stricken look, short-term memory loss, ADHD-like behaviors, tics, learning problems, sensory sensitivities, eating disorders. Great description. Okay, so I want to get back down to how does this work? What's the pathophysiology of autoimmune encephalitis? What we're talking about is immune cross-reactivity between microbes and host tissues, which we call molecular mimicry, and this triggers an autoimmune inflammation. Okay, I think I just probably went past a few people here, and I'm going to break it down by describing rheumatic fever. Rheumatic fever, which we don't see nowadays, which is nice, is when people would get a strep throat. The antibodies to the strep would attack the heart valves because there's a structural similarity between the strep microbe and the heart valve. So the immune system gets confused. Hey, these guys look alike. So it's an autoimmune reaction, but it's also an infection. It's triggered by this infection. That's what we refer to as molecular mimicry, okay? Our own cells are mimicking the microbe. And what we end up with is this autoimmune inflammation. Now, take that concept of rheumatic fever, and if it's autoimmune encephalitis, the antibodies are attacking the brain, not the heart valves. It's that simple. We got antibodies to microbes that are now attacking the brain. So children with PANDAS and PANS-like conditions exhibit elevated levels of several antineuronal antibodies on dopamine receptors, lysoganglioside, tubulin. These are in the brain. Okay, when these antineuronal antibodies cross the blood-brain barrier, they activate an enzyme, calcium calmodulin dependent protein kinase 2, which we're going to call CAMK2. I promise not to say the full name again. So CAMK2 mediates many learning, memory, and developmental cell pathways. CAMK2 alters dopamine transmission, which is associated with neuropsychiatric disorders and involuntary movements. So there you have it. That's the pathophysiology right there. There are issues that have to do with why these antineuronal antibodies can cross the blood-brain barrier, but they do. So the Cunningham panel, that's named after Madeline Cunningham, who did the ground level work for this. The Cunningham panel measures these 4 antineuronal antibodies and the activity of CAMK2. So we're going to talk about the Cunningham panel. There's your 4 antibodies and then the enzyme activity. And now I'll tell you about a study. This study was, the primary investigator was Craig Shimasaki. He's a molecular labs, but there is well over a dozen practitioners who contributed to this study. And they took over 250 children and adolescents who seemed to have PANS and PANDAS-like syndromes, and they narrowed it down to 58 that made strict criteria so everyone could agree, yes, these kids have it. Out of those 58, they tested them before and after treatment. 34 of the 58 with treatment reportedly improved or even resolved. 24 of them did not improve or even worsened. There was a strong positive correlation between neuropsychiatric symptoms and the Cunningham panel, antineuronal antibodies and CAMK2 activation. In fact, there was a very high sensitivity and specificity that correlated the Cunningham panel with the patient's neuropsychiatric symptoms. My point is, this is a good test, and we're going to come back to it. Okay, so case 2 is Maddie, whom I met when she was 14 years old. I love Maddie. I think she's great. She had complaints since childhood, depression with dark, intrusive thoughts. I mean, it's one of the things I ask about, they get thoughts like they're being told to hurt themselves or hurt their siblings. Anxiety, she had phobias and panic attacks. Actually, she was also agoraphobic. She didn't want to leave the house. OCD, constipation, enuresis, which is bedwetting, syncopal episodes, passing out, palpitations, sleep disorder, drenching night sweats, chest pain, air hunger, muscle cramps, numbness, and tingling. This poor, obviously you can just look at that and see and feel the dysregulation of her regulatory systems. Physical exam was remarkable for POTS. Again, dysautonomia, we see it so prominently in these kids. Prominent stria on the legs, arms, and breasts, and memory loss. So her laboratory was positive for Lyme, it was positive for Babesia. She had a positive IgG to multiple foods. And there's the back of her legs. This is just one place that exhibited the stria. Multiple other pictures. Here's one that it's a little hard to see, but right here, if you're seeing her arm, you'd say, oh yeah, the picture doesn't show it up quite as well. Okay, and here's her Cunningham panel. I mean, check it out. It's really high anti-dopamine receptor D1, high anti-lysoganglioside, high anti-tubulin, and elevated activity of CAMK2. Yes, here's the thing. She had polymicrobial tick-borne infections, including Lyme, Bartonella, and Babesia. She clearly had dysautonomia, which was manifest in POTS in particular. She had multiple food sensitivities. She did not have PANS technically. I mean, she had everything that goes along with PANS, right? But she did not have the acute onset. She had sort of a stuttering, gradually worsening onset. So we're going to call it autoimmune encephalitis. And this is important because some of you are going to see doctors who are going to be real sticklers and say, well, this was not an acute onset. It's not PANS. Well, okay, it's not PANS, but it is autoimmune encephalitis, and it's the same pathophysiology. Okay, case 3 is Anna. I met Anna when she was 18. As a child, she had sensory integration disorder, speech problems, eye tracking issues, constipation, the odd hand movements, the choreiform movements I mentioned, the facial grimacing, which is tics. She did have OCD. And then things got worse. As teen, she had sleep problems, depression, anxiety, mania at nighttime, migraines, muscle aches and joint pains, knee swelling, itching, nausea, heartburn, sugar cravings, recurrent viral infections, pins and needles, numbness, flushing, hot and cold. She was diagnosed basically as having atypical bipolar. Physical exam was fairly unremarkable except dermatographia. Okay, so here's what dermatographia is. It's when you scratch yourself, say on the inside of your forearm, and you go like that with your nail, and you wait 30 to 60 seconds, and often a red line will develop. Sometimes it's white, or more often it's red or pink with pale on either side. And that is evidence of excessive histamine and mast cell activation. So her laboratory showed low thyroid. And this is very interesting. You know, she had a weird sleep schedule and she was so tired all day. It turned out that she was tired all day, but around 10, 11 o'clock at night, she would start to wake up, and between 12 and 5, she was manic. I mean, she described herself sort of like a hamster on a wheel. She was moving all the time. But she had a morning cortisol level done by a local endocrinologist. It was low, and local endocrinologist said, wow, you have adrenal insufficiency, and put her on a low dose of hydrocortisone. And I said, wow, that looks like you were really low there. I saw the numbers. I said, but let's get a cortisol 11 p.m. Well, it was high. She had a reversed cortisol pattern. And so she had the cortisol pattern of someone who, say, would be working the night shift, when cortisol would be high at night and then low during the day. And that's what she was doing. She was up all night and then she would sleep until early afternoon. Okay, she also had mold toxins in the urine. You know, I mentioned this, even though it's way more than I can get into in this talk, but she had methylation mutations and I see this pattern. I'm mentioning it now only because I see this pattern a lot in my PANS patients. I mean, in most of them, where she has 2 mutations at the MTHFR gene that should result in an elevated homocysteine, but it's a low homocysteine. I confess I do write about this in some detail in my book, but what happens is there's an upregulation of a transsulfuration pathway, and this results in low glutathione levels, low SAMI. It's a very, very challenging detox profile, and I see it in most of my patients with PANS. Here is her Cunningham panel, and you can again see anti-tubulin antibody is increased and CAMK2 activity is increased. Okay, moving right along. So Anna's diagnoses, excuse me. Again, polymicrobial tick-borne infections, Lyme, Bartonella, Babesia, low thyroid, reverse cortisol, mast cell activation syndrome, mold and mycotoxin illness. She does have bipolar disorder, and she also has autoimmune encephalitis. Yeah, she has a PANS-like syndrome, no question. She has PANS, but technically it's not PANS because she did not have the sudden acute onset of falling off a cliff. She just had gradually getting worse and worse over the years. And now Thomas. Okay. I met Thomas when he was 17. At 2 years old, this is really interesting. At 2 years old, he had fever and he was lethargic. His laboratory is remarkable for very low platelets. Now, excuse me, he did recover. But that syndrome is called ITP for idiopathic thrombocytopenic purpura. Well, sometimes it's idiopathic. Sometimes we know what causes it. People who read the New York Times, sometime in the past 6 months, there was a case like this in their medical section in the magazine. Okay, so he had ITP and he recovered. But then he became, according to his mom, a scary child, violent tantrums. And they slowly got better by the time he was 4. It turns out Bartonella can trigger an ITP syndrome. Bartonella can trigger a lot of autoimmune illnesses. ITP is one of them, and I suspect, we'll never be able to prove it, I suspect that Thomas had Bartonella infection when he was 2 years old, and that's why he ended up having violent tantrums. Okay, he did recover. His immune system seemed to keep that in check, and at 12 years old, he's in Oregon, he's in summer camp, and he starts running a fever. They bring him home, a really high fever, and then he falls off a cliff. Severe OCD. When I say severe OCD, this is the worst I ever heard of. His mother described to me that he was in the shower for 5 hours and they had to get the police to pull him out. Severe anxiety and agitation, rage, violent behavior, anorexia, really anorexia nervosa. At 17 years old, when I met him, he was 70 pounds. Psychosis, clearly had cognitive impairment and tics. Okay, Thomas is a poster child for PANDAS. He just checks off all the boxes. Here's his Cunningham panel. You can see it's similar to Anna's elevated antitubulin, antibody, elevated activity of CAMK2. So what does he have? Polymicrobial tick-borne infections, right? He's got Lyme and Bartonella babesia. He also tested positive to mycoplasma. He does have mast cell activation syndrome. He does have mycotoxin illness, and he has PANDAS, but, it's all, it's not like these are separate diagnoses. They wrap around each other. Okay. So I want to tell you about a pilot study we did. And in this pilot study was triggered by Danielle with the anorexia nervosa that got better. A doctor who was training with me and sitting in, I said to Dr. Nancy Brown, I said, Nancy, wouldn't it be good if we could go into a eating disorder unit and test everyone and see how many had tick-borne infections and autoimmune encephalitis? And she said, well, how about this? I'm medical director at a residential treatment center for adolescents who can't make it at home. They don't treat eating disorders. They just don't have the provisions to do that. But they all have major depressive disorder. So we got permission, we got an IRB to basically just test 10 kids at random in this residential treatment center. And this is in Colorado, by the way. It's still a state where the Department of Health claims you can't get Lyme. Somehow the ticks stop at the border kind of thing. Okay, so we tested 10 kids, all of whom had major depressive disorder. They couldn't make it at home. They couldn't make it at home. They couldn't go to public school. They were just hanging on. Many of them, well, 4 of them had made significant suicide attempts. There was cutting. But here's the thing. There was no known organic disorder, no known physical disorder, with the exception of one kid who was diagnosed with celiac disease. So we tested them, and 6 out of the 10 had antibodies to tick-borne pathogens, Lyme, Bartonella, and/or tick-borne relapsing fever, consistent with exposure, that they had been exposed to these microbes. And you might ask, well, why do we just test those 3? It's because this is what IGeneX would do for free, which we're very grateful for. But 6 out of 10, and depending, we're looking at antibody panels, right? Depending on how you interpret those antibody panels, maybe 9 out of 10 had probable exposure to tick-borne pathogens. And remember, we live in Colorado. 3 out of 10 had elevated anti-DNase B antibodies, so that's antibodies to strep, high levels of strep antibodies. But check this out, this blew us away. 9 out of 10 of these kids, they did not have PAN syndromes per se. They had mainly major depressive disorder and anxiety syndromes. 9 out of 10 had elevated anti-neural antibodies consistent with autoimmune encephalitis. 9 out of 10 had positive Cunningham panels. I thought this was huge. And here it is. We wrote it up and it was published, and you can check that out. microbial-induced autoimmune inflammation as a cause of mental illness in adolescents, a case series. But, you know, what can we conclude? Well, I want to point out that this autoimmune inflammation, it doesn't only manifest with PANS. It can just cause depression and anxiety. And, you know, it's now, there is so many medical journal articles coming out describing inflammation in mental health disorders and connecting it with autoimmunity. There's a plethora of articles on this. So it doesn't have to be PANS, doesn't have to be OCD, it doesn't have to be eating disorders. But depression and anxiety in adolescence is often caused by an organic illness. And I'm going to call it, instead of PANS or PANDAS, but microbe-induced autoimmune encephalitis, okay, MANS. I confess I made that up, but I'm really trying to get it into the literature. I've had 2 or 3 articles so far. So moving right along, there are 2 major players in the context of tick-borne infections that cause mental health issues: Bartonella and Mycoplasma. I did write an article on, does Lyme cause PANS? And the answer is, we don't know, because we don't see Lyme without the co-infection. So how do you isolate that? There's circumstantial evidence that the Lyme spirochete, Borrelia burgdorferi, probably can trigger a PANS syndrome. What we know is there are a lot of kids with Lyme who develop PANS, but they all have co-infection. So how can we blame it on them? Well, what I can tell you is Bartonella and Mycoplasma, we can blame these 2 pathogens as triggering PANS syndromes. I just want to point out Bartonella is maybe the worst of the different tick-borne infections that I see. It causes the most inflammation, most autoimmune problems, and the worst of the neuropsychiatric problems. When I see someone with psychosis, when I saw Thomas, you know, who had his story was he probably had babesia, right? Acute babesia, because he had an acute fever of 104 degrees. That's almost always babesia. So, and he got tested by another doctor who documented babesia. So we know he's got tick-borne infections. And I said, I will put money on it that he's got Bartonella, that, you know, he has such severe neuropsychiatric problems. And in fact, when we did some more aggressive testing, we were able to actually find a positive RNA test for did I say babesia before? Bartonella, that he does have Bartonella. Bartonella is the worst. And this is just Bartonella here. Look, Bartonella has been shown to cause anxiety, panic attacks, depression, OCD, anger, rage, oppositional defiance disorder, phobias, substance abuse, personality disorders, psychosis, bipolar disease, PANS. This has been documented. Bartonella causing PANS. Schizophrenia and schizoaffective disorder. This is I thought an amazing study done by Ed Breitschwert and colleagues. Ed is leading Bartonella expert in the country, and I presume the world. And they took 33 adult patients with the recent onset of neuropsychiatric symptoms. Right there, you have to wonder, like, okay, if there wasn't any obvious stress trigger, you know, family history, why did an adult patient suddenly develop, you know, depression or anxiety out of the blue? Okay, well, these 33 did. And here you can see how it would manifest. 23 of them had irritability or even rage. 22 anxiety and or with or without panic attacks, depression. I mean, these were significant neuropsych symptoms, and they had a potpourri of other complaints: sleep problems, confusion, headaches, and so on. Okay, out of those 33 adult patients, adults with recent onset mental illness, 29 of them tested positive either by antibodies or PCR, which is DNA evidence of Bartonella. And you might say, well, you know, what about a control population? What would that look like? And it's a very good question, because you could probably find 10, 15% of people who have Bartonella who are walking around and are fine. But what you would not find is 29 of 33 control population testing positive for Bartonella. And it keeps getting better. 24 of these 29 had concurrent cutaneous lesions. They had skin problems. Most of them were the Bartonella stria, which I mentioned already. You can biopsy them and actually see the Bartonella microbe. So check this out. This is someone's back. I've had a few patients that look like this. Looks like this person's been whipped, right? These are not stretch marks. I mean, think of it. Who has stretch marks that are in that sort of pattern? The stria are not in the same planes. Here's some more. This is someone's armpit. It's very obvious. And they can be pink, red, violaceous, but sometimes they're pale. And sometimes they were red, but then they turn pale in skin color. And you only see them if you're looking at the correct angle. There's some more right around the waist. I would say the most common place is the upper thighs, around the hips. And most people assume that, oh, those are stretch marks. But if you look carefully, they really are not consistent with stretch marks. Okay, so that's Bartonella. Bartonella is the worst actor as far as I'm concerned. And if I see anyone who has Lyme and tick-borne infections and has severe neuropsychiatric problems, I'm going to think real hard that this person might have Bartonella. Okay, what about mycoplasma? Now, mycoplasma is a respiratory pathogen, usually. Mycoplasma can cause colds, sore throats, ear infections. Very common cause of bronchitis and pneumonia in adults. But guess what? It can also cause neuro problems. It can cause acute psychosis, OCD, mania, eating disorders, and PANDAS. This has been documented as well. I can tell you that almost all now remember, I'm seeing people with tick-borne infections, and almost all of my patients with tick-borne infections who have PANDAS-like syndromes have Bartonella, and at least half of them also have mycoplasma. Now, to diagnose mycoplasma, again, I'm gonna say you might want to read my book, but because most of us have some antibodies to mycoplasma, but depending on the level of antibodies and whether the IgM antibody is also positive, that can help you make the diagnosis. Okay, so now we're coming back to microbe-induced autoimmune neuropsychiatric syndrome. I much prefer this term to PANDAS because it's just more general. MANS is what I just said, autoimmune encephalitis triggered by a microbe resulting in psychiatric symptoms. That's MANS. It can apply to all age groups, and we see PANDAS-like syndromes in adults, but it's more like those kids in the residential treatment center. They're complaining of depression, anxiety, irritability, and sometimes, you know, those other symptoms down the list, frequently other symptoms down the list. And, you know, we can't call it PANDAS. For one thing, they often don't have OCD and they don't have an eating disorder, although sometimes, particularly OCD, can start playing a role sometimes. But if you start testing people who've had Lyme, you can find positive Cunningham panels in people with these ongoing neuropsychiatric symptoms. And so the two big differences between MANS and PANDAS is that it applies to all age groups, but also the onset can be rapid like PANDAS, but it might be slow or stuttering onset, which is more often what I see in children and adolescents, not just adults. And PANS, it's limited to children and adolescents. It's limited to those with the sudden onset of symptoms and that meet those criteria for PANS that we discussed. Okay, folks, so we're winding into what do we do? Well, antibiotics, remember that the pathogen, the microbe is the trigger for this inflammation, and we want to get rid of the trigger. Like with rheumatic fever, you got strep in the throat and you got the immune system attacking the heart valves. You need to get rid of the strep in the throat, antibiotics. And in some cases, we're using intravenous agents. And if we're talking about tick-borne infections, cover the co-infections. I already mentioned that Bartonella and Mycoplasma are really prominent in this context. And beware of Herxheimer reactions. Okay, so for those of you who don't know, a Herxheimer reaction is also known as a die-off reaction. Basically, it's a flare in symptoms associated with killing the bugs. There are fragments of the bugs, mainly in the cell walls that can trigger a cytokine cascade. Now with COVID, everyone's heard of cytokine cascade. It's an inflammatory cascade. And it can make everything worse. And when you're talking about somewhat neuroinflammation, you can turn someone psychotic who just was anxious. You really don't want to do that. And it's not just because it's ridiculously awful for the patient, but it's increasing the inflammation in the brain. So you need to be very gentle when you're starting antibiotics. Anti-inflammatory agents, NSAIDs, like these are non-steroidal anti-inflammatory drugs like ibuprofen, sometimes can really be helpful. Obviously, you have to be careful about the stomach lining and the kidneys. Intravenous gamma globulin, I've seen it be somewhat miraculous. The biggest limitation of getting intravenous gamma globulin is insurance coverage, because you have to be like Bill Gates to afford it out of pocket. Basically, what you're doing is you're giving someone antibodies that have been taken from, I don't know, thousands of donors. And you might say, whoa, wait a minute, what are the chances of passing on a bug? And all I can tell you is after decades of doing this, it's never happened. I guess they, good screening and filtration, but in some cases, it can make a huge difference. And what we're doing with this IVIG is we're not only stimulating the immune system, but it also has an anti-inflammatory effect. It's actually suppressing some T cell lines. And in some cases, it can make a world of difference. And there's really good literature behind it. Nutraceuticals, okay, these are nutritional supplements that can decrease inflammation. You know about these things. And I would include CBD with that. And, if you look at what Stanford recommends, they put kids on a short course of corticosteroids. I do not recommend that, certainly not in my patient population. I've seen kids get worse from this, because what are we doing? Yeah, you're decreasing inflammation temporarily, but you're also suppressing the immune system even more, and then the bugs can come out and party. Okay, and psychotropic medications clearly have a role, even if they're Band-Aids, but kids are suffering, and I'm sure you know that better than anyone. Awful, it's awful being anxious. It's awful being so depressed. It's awful being psychotic. I mean, so, I do have a couple of psychiatrists in the area that I work with who seeing these kids and helping out with prescribing these medications. I think it's really important. We, even if we're not treating the root cause, we're helping these kids take a deep breath and not feel so awful. But what else? Those three things are the headline treatment. But most of my patients have food sensitivities that can, once their system has become inflamed, they become sensitized, and now they're reacting to all sorts of things. In the food category, these are the most common allergens I've seen in my patient population: gluten, dairy, eggs, and corn. And really, I've seen like corn in a kid suddenly shut them down and they won't eat. I've seen sugar, which I should have put on here, sugar and yeast. I've seen that provoke anxiety attacks. And just as the system can get sensitized to foods, it can get sensitized to mold, and mold might not have been a problem. It might not have been a problem before they got sick. But once their system became inflamed and sensitized, now the mold's an issue. So mold can generate this inflammation resulting in neuropsych stuff. And then the mold can also generate mold toxins, which, guess what? They can do to the brain just what these bugs do. Dysautonomia, I'm just going to explain that a little bit for those of you who are not acquainted. So we're talking about the autonomic nervous system. The autonomic nervous system is that part of our nervous system that works automatically. So we don't think about our blood pressure and our pulse. We don't think of how fast to breathe. We don't think about our circulation and where to send blood at any particular time. Our autonomic nervous system does that. And I know it's an oversimplification, but there's two main arms. There's the sympathetic arm. So the sympathetic arm is mainly stimulatory, and then there's a parasympathetic arm, which is mainly calming. And the whole point of a healthy autonomic nervous system is to keep us in homeostasis, well balanced, right? But if our system is inflamed, the autonomic nervous system can wacko. And that's one of the things we see in POTS, postural orthostatic tachycardia syndrome, where people stand up and their pulse races. I've had patients go from a pulse of 80 to a pulse of 140 when they stand up. That's typically associated with lightheadedness and even syncope, which is passing out. Also, the blood pressure can drop. But dysautonomia can cause anxiety. It can cause gastrointestinal symptoms, heat and cold intolerance, and sweats. You know, there's a long list of symptoms associated with dysautonomia. And among tick-borne infections, Babesia is the strongest generator of dysautonomic symptoms. Mast cell activation syndrome. Okay, a quick explanation. Mast cells are primitive white cells. They contain almost 200 inflammatory mediators. And when they get triggered, they release them. It's called a process called degranulation. And it causes inflammation. Now, mast cells are iconically associated with allergic reactions. And in fact, if you have hay fever, eczema, hives, anaphylaxis, all of this is generated by mast cell degranulation. But it can cause all sorts of inflammatory syndromes, including migraine headaches and cognitive dysfunction and muscle aches and shoulder pains and asthma, shortness of breath, et cetera, et cetera. Dysautonomia and mast cell activation syndrome are very, very connected. And it's illustrative of how much the nervous system and immune system are not separate systems. And then there's methylation issues. I made reference to methylation problems with Anna, way too complicated to deal with in this particular presentation, but I do give a detailed explanation in my book, and general nutritional support, which is also pretty broad-based general. So that's the treatment. You know, the first three, you know, antibiotics, anti-inflammatory agents, and psychotropic meds. And then looking at what else is going on to try to stabilize these poor kids. Okay, so let's take a step back. Mental health issues, I'm sure all of you are aware, they are increasing. They're increasing in youth, they're increasing in adults as well, right? But we're talking about youth. And, you know, and it's getting crazy. And we know there are multiple well-known psychological stresses. And now the Surgeon General is coming out talking about screen time. And I totally agree. You know, I grew up in a different era, obviously. And I, you know, I can see how, you know, the isolation and the attention issues with this. And yeah, it's weird. It's weird to me. But in addition to the psychological stresses, what about organic issues? Autoimmune illnesses are rising. Tick-borne infections, that's where we started, they're epidemic. So I'm asking, is autoimmune encephalitis an important reason that our children are increasingly anxious, depressed, violent, and suicidal? And it doesn't need to be one thing. So this is a diagram I stole from my book, The Beaker Metaphor, is some of the environmental docs talked about 30, 40 years ago. That, we might blame the last issue as that which spills over into an illness, but all of the things that precede it, genetic and congenital issues, diet, nutrition, emotional stresses, kids who had adverse childhood experiences of 2 or more. So, we're talking about major stresses of childhood. They have like an 80% increase in autoimmune illnesses resulting in hospitalization. Yes, that's right. Stress causes, I don't know if that's the right word, but stress can lead to autoimmunity. And then, so, these are all things that can happen to us, right? Physical trauma, can really throw our bodies off. Toxin exposure, and which, unfortunately, all of us are exposed to. And oh my God, look what happened to New York City, Northeast. Gabriella's in Connecticut. She witnessed it firsthand. And, and illicit and illicit drugs, alcohol, of course. And like I said, someone might get Lyme or strep or something, and then say, well, that's why I'm sick. But really, it's always multifactorial. There's always a few things going on. And I should emphasize the genetic part of it, because genetics can be a strong predisposer to autoimmune illness. Okay, so what can you do? Get educated, and that's why you're here today. Bless you. I know how much suffering there is in both the children and adolescents suffering from this, as well as their parents and family. It is huge and it's awful. So in addition to educating yourself, see what you can do to educate your pediatricians, your psychiatrists, your psychotherapists, as well as your children, and explain it's not their fault. They're having terrible, intrusive thoughts. They're telling them to kill their siblings, and anxious, and just say, look, you're seeing the world through a very distorted lens right now, and it's not the real world, and just hang in there until we can get these lenses cleaned up. So that's my talk for today. I just want to thank you for attending. I want to thank Gabriella for putting this all together, and God bless. I wish you the best.
Thank you so much. So informative. It's always amazing how much all of our speakers can get into an hour into a lecture. We have a few questions from the audience, and of course, there were some that we went through prior to this of what you can answer. So I guess a good one to start with would be just about testing. You mentioned IGeneX in your talk. What's your go-to when you have a person come in? What are your go-tos?
Yeah, it's a really good question. My initial testing is usually, well, let me take a step back. I really think IGeneX is the best tick-borne testing lab in the country, if not the world. And I know there's whisper campaigns against IGeneX by the CDC and university settings and so on. And that's all it is, whisper campaigns, because they don't like all sorts of people getting diagnosed with Lyme disease for, political reasons. So, but they do an excellent job, and they've been doing an excellent job for a few decades now, and they're getting better all the time. So if I'm testing for Lyme disease, I'll order a Lyme immunoblot, IgM and IgG. It's also important to know how to interpret it, though. They have criteria for positivity, and they also have the CDC criteria, which are stupid. But but that's where I start. And again, in my book, I describe, here's how to interpret these tests. It's not just looking at, is it positive or negative? But the next thing that's going to happen when I see a patient, they sort of need that positive test to get in and see me. And then after they come in and see me, I take a history. I mean, I spend 3 hours with a patient the first time I see them. And often just from the history, I can tell, hey, this person's got babesia, like Anna, case number 3, I think she, all these night sweats and dysautonomia. It was obvious she had babesia. Or I can't remember Maddie, with those Bartonella. I mean, it doesn't matter what the blood test shows. It may or may not show Bartonella, but we can just skip it, because she clearly has that. So that's where I start. And I will say, if you want, because insurance will cover it, go ahead and test at LabCorp or Quest or your hospital lab. But if it's negative, don't stop there. I can go through a handful of reasons why it's just inadequate testing. It's just going to miss a majority of people. And, it's just really, it's upsetting, as I talked about. It's upsetting, like what's happened in terms of that. So I start with an IGNX immunoblot. And then if I can't discern, are there co-infections here, I will use further testing, particularly for babesia and Bartonella. But if they're negative, it doesn't rule it out. I think the immunoblot for Lyme is quite sensitive, but the testing for babesia not quite as good, and the testing for Bartonella not as good as babesia. So I might still suspect those diagnoses, and I might give them an antimicrobial targeting babesia, for example, and see, do they get better or do they hurt or nothing? If there's no response at all, I probably don't have it. And the same with Bartonella.
So what are your thoughts on, say, DNA connections and a DNA type test?
I'm going to guess it was, since the pandemic, I can't keep time frame references in my head. Like, how long ago was it? It was like 5 years ago. I'm going to guess that, these DNA connections started coming across my desk, and I'm like, whoa, wow, that's amazing. A urine test is going to diagnose all these things. And I called up Dr. Shah at IGNX, and I said, you know about this? They're doing DNA tests on the urine. And she said, no, I never heard of that lab, but we've been trying to do that for over a decade, and we haven't been able to get it right.
Yeah.
And as I looked at these results coming across my desk, they were A, not correlating with the IGNX results. B, they were not correlating with my clinical acumen in terms of what was going on in the patients. It just wasn't lining up. And so I will say that because of DNA connections, IGNX started offering that test more recently, but they're not beholden to it. They say, it's got a low sensitivity or something. It's not one of their premier tests. They're just offering it because people are asking for it. But they say it's got false positives and negatives.
Thank you. And how often do you run the molecular Cunningham panel? Or
wow.
How do you determine when you're going to run it? I guess is a better question.
This is really a challenge. It now costs over $1,000.
Yes.
And, insurance may or may not cover that. So it's a big hit. And I would say that if there's any question diagnostically, what's going on, and if we need that data to try to convince other practitioners, I'm going to run it. But often, well, the definition is not a laboratory-based definition. The criteria are all clinical to make the diagnosis. And I don't really need the Cunningham panel. Here's what I think, Gabriella, that if someone presents with an obvious PANDAS-like syndrome, you don't need the Cunningham panel. I think it's like great information to be able to confirm, but your clinical experience with that patient, but it's also, not necessary in many of them. However, let's say you have a kid with major depressive disorder, doesn't have an eating disorder, doesn't have OCD. That would be a good kid to test. I have to, I'll mention, like, I saw a girl, let's see, she's 13 years old. And she has now an eating disorder, and she's cutting, and she's not clinically depressed. She's shy and has some anxiety, but she's 13 years old. She's not sick to look at her. And, she gets along great with her family, which is very warm and loving. And if you saw her, you'd say, she looks like a happy kid. And even though she's been purging, she looks good. Well, she also has Lyme, Babesia, Bartonella, and a positive Cunningham panel. Excuse me. And she's really not in control of her purging and her cutting. It's not something you can just talk to her about and put her in therapy and give her an SSRI and watch her turn around. She's got infections that have to be treated. But, when I saw this person, I thought, wow, the kids I'm used to seeing, they want to get better. They're sick. It's, if they're not pulling their hair out, their parents are, right? And this person doesn't even look sick, and she doesn't even want to stop these behaviors. She's like happy doing it. Well, I actually emailed Bob Bransfield, that many of you would know. Bob Bransfield he's written more on neuropsychiatric Lyme than anybody anywhere. And I said, do you see this with tick-borne infections and autoimmune encephalitis? The kid's not sick. She doesn't want to get better, but she's got these, behaviors that are self-harm. And he said, he said, absolutely, we see this. And I realized that I don't see these people because they're not sick enough to reach me. And I don't see these people because who would think to test them for tick-borne infections and Cunningham panels when, they look good. They look good, right? But just think of how many kids out there are going to fit that description who are never going to get tested because they're not sick in that medical sense.
Right. It's the bias of looking well.
Yes. And another bias is going to be all the parents who say, I think my kids have PANS, and their pediatricians say, I don't believe in PANS.
Yes, one we're all very well aware of too.
Yeah.
One more testing question, and then we'll move along, is do you test regularly for Borrelia miyamotoi in your practice?
That's an interesting question. So for people to know, Borrelia miyamotoi is a Borrelia species, but it's a whole different category than Borrelia burgdorferi. It's in the relapsing fever group. And if you look up relapsing fever, it'll describe people who are well, and then they have the sudden onset of very high fever, 105, 107 degrees even. And then it suddenly defervesces. The temperature comes down. And you can imagine all the symptoms you have during that time of increasing and decreasing fevers. And then you're fine again, and a week later it happens again. So that's relapsing fever. Turns out Borrelia miyamotoi, which has an interesting history behind it, it actually tends to cause Lyme-like illness. And that is something I would test for only if they did not test positive for Lyme, because the treatment's the same. And if they have miyamotoi, but also have Lyme, the treatment isn't going to change. But if they have some sort of illness that I can't pin down, then, that's one of the things I'm going to look for. And this is interesting. So there's a doctor in the general area where I live who's contacted me about a woman with dementia. And she did an IGNX panel on her. And then the only thing that came up was tick-borne relapsing fever. And so she started treating her, or she wanted to know what I thought. And I said, well, go ahead and put her on antibiotics and then repeat the panel in a month. And at that point, I think she ended up being positive also for Lyme and Bartonella. And so now she's on broader treatment. So the antibiotics, which can stir up the bugs, and then the bugs stir up the immune system. And what we're doing is an antibody test that can demonstrate it.
Because one of our professional advisory board members, Dr. Delaney, she's done a lot of work on me and Motoy. So it's always sort of in my radar to talk about that too. So, well, you could test that too. So you talked about the difference between the Bark striae and stretch marks. And you can tell the difference. And a lot of doctors don't, or they don't want to. That's a whole nother story. But when it's on the hips and the places that we often get are more inclined to get stretch marks, how do you tell? Like, especially in a kid who may have suddenly gained weight or has been overweight, like, how do you tell? Or is your eye just so trained you?
You know, it's funny. You remember the Supreme Court Justice says, I don't know how to define pornography, but I know what it is when I see it. It's sort of the same. You know, I've seen so much of this, and it really does look different than stretch marks. There's often, you know, cross hatching, and often is not coincident with weight gain, even though it can be. And how else, you know, they can be biopsied, that's for sure. And like I said, it's a different level of the dermis. It's a different pathology. But I'll also say, when I saw the dermatologist, and I for just my yearly checkup, and I said, "You ever see Bartonella stria?" And she said, "Only in my boards." But that was a good answer. I mean, I appreciated that there was a recognition by dermatologists that there is such a thing as Bartonella stria, and it's not, you know, because you'll see all these quackbusters things on websites. You know, I don't have a good answer for that, other than to say, if you look carefully, to me, they look very different than stretch marks.
Yeah, I mean, when you put the one of the armpit up, I was like, wait, is that my kid? It was so startling. I was like, yep, seen that. And those came up in a day. Like, they were there, and then they weren't there, and suddenly they were there. In your opinion, if you push them and they blanch, is that more indicative of striae than? Because I've heard a couple of doctors say, oh, if they blanch, it's Bark. So I was wondering your thoughts on that.
Yeah, you know, it's interesting. Why didn't I ever do that? I don't think I ever have, but they should blanch. They should blanch because they're vascular.
Right.
You know, that's what we're seeing. We're seeing new blood vessel formation, which goes along with, you know, one of the tests we do that suggests Bartonella is an elevated VEGF, vascular endothelial growth factor. It's a cytokine that's involved with stimulating blood vessel formation. This is one of the things that Patterson, who's been looking a lot at post-COVID patients, is finding elevated VEGF. I actually think most of those people have reactivation of their Bartonella from the COVID virus and or the COVID vaccine. And because I've seen that a lot. I've seen, you know, people who develop long COVID or severe reactions from the vaccine. Often it's if they did have tick-borne infections, it can really flare them, Bartonella being the worst. Yes, if it makes sense to me that if you press on them, they will blanch.
Okay. And then, just like COVID or the vaccine to COVID can stir things back up, what are your thoughts on a sudden acute stress? Do you see those striae come back out and all the Bartonella symptoms come raging all of a sudden with an acute stress?
Yes, thanks for asking. So when I see people go from okay to not okay, I always want to know why. and so there's this long list of things that can do it. And it can be, emotional trauma can be high on the list. Emotional trauma will suppress the immune system, very well documented in the literature.
And it
Uh,
opens the blood-brain barrier and causes inflammation. So that's
Yes.
a triple whammy.
It's a triple whammy. And, I'm PTSD, unbelievable amounts of inflammation, immune suppression, neuroinflammation. It's basically the same pathophysiology as Lyme, and then you put the two together or you get Lyme and it gives you PTSD it can do that many ways, right? So there's no question, I always want to know, well, what happened, and I would put emotional stress high on the list.
Yeah, and it falls in your beaker analogy picture and stresses.
Right.
One more question about that striae, which came in through the chat. Where does one get a biopsy of the striae?
Well, you have to see a dermatologist to do that. Yeah.
And do you think they're open to that?
Depends on the dermatologist. Depends how inquisitive they are.
Right.
I just want to share a story that's very tangential, but I get such a kick out of it. This patient has Morgellons. So as people, the audience may or may not know, Morgellons is a syndrome in which fibers come out of the skin, and no one understands, like, what are these things and why does that happen? They typically are associated with Lyme and tick-borne infections, but exactly how this happens, we really don't know. And when Western docs don't know, they blame it on the patient. And so still in the existing literature, Morgellons is referred to as, delusional parasitosis, right? These people are somehow delusional, like psychotic, that they think they have some parasite in them and that's generating these things, except that, guess what? They're real. So my patient is seeing the dermatologist. He takes some fibers, put them under microscope, and he says, I don't know what the heck this is. And my patient says to the doctor, well, I guess we're both delusional. I thought that was so great.
Yeah, sort of perfect. And then there was a question that came in about neuropathy. If Lyme-induced neuropathy doesn't resolve post-treatment, does that mean it's not infection mediated?
Okay, so remember that these microbes stimulate autoimmune problems. The first thing I would wonder is, does the patient have Bartonella and has it been adequately treated? Because Bartonella tends to cause the worst neuropathy of the bugs. Now, it's not the only pathogen that can trigger neuropathy. Babesia does it a lot, and Lyme does it somewhat. But Bartonella does it big time. And Bartonella it's probably also the hardest to get rid of. It just has amazing ways to hide, and it's an intracellular bug, so it can hide inside cells, it can hide inside tissues that the immune system and the antibiotics can't get to, and it causes inflammation. It generates inflammation. So it's a frequent cause of neuropathy, and that's the first thing I would wonder. But there is a possibility that a patient could continue to have autoimmune problems even after the bugs are eradicated. That said, I never claim that the bugs are eradicated, right. Even when people, it's interesting, I have an occasional patient who 10, 20 years down the line is free of any symptoms, and we'd like to say they're cured. All we say is they've been in long-term remission. We have no way of knowing whether these bugs are gone again. We don't have any tests that say the bugs are gone.
Okay, one last striae question. So say we treat medically and they start to fade and they're not that red, fiery red. do they go away? Like the, the sort of the traces of them go away? Does the skin clear up, or do you always see little bits of them, and sort of that faded?
Yeah, that's a really good question because they don't go away totally. They become pale and skin colored. And even to the point where when I'm examining a patient, sometimes I have to like catch it in the right light to notice it. And if you put your hand over it, you can actually feel them. It's subtle, but if you just saw this person in a bathing suit, a few feet away, you wouldn't even notice.
Okay.
Until you got really close and got at the right angle, and you'd see these very pale lines in the skin.
Yeah. I remember one day there was this kid in line to rent a surfboard in front of me, and he had the horizontal, deep, fiery red stretch marks across his back. And I was just standing there. I was like, God, that's definitely, I mean, not that I'm a diagnostician, I'm not a doctor, but I turned to his mother and I was like, hi, you don't know me at all. But you may want to look into Bartonella. And we exchanged information. And about 6 months later, she was like, yeah, after we had a couple holes punched into our wall, it was definitely, we tested and it was definitely Bart. So you can, sometimes you can really see them, but sometimes, I mean, that was pre-treatment, but they can look remarkably different. One last question.
I should mention, Bartonella is really famous as cat scratch disease.
Right.
So I should just mention that most doctors are going to associate Bartonella with cat scratch disease, not with tick-borne infections. Some of us, I know, are good friends with Joe Birascano, who talks a lot about Bartonella, and we both think Bartonella may be more common than Lyme disease. Problem is, you don't know because the tests are so bad, and doctors don't even think to test for it. But think of that study that Ed Breitschwert did with, these are people, they weren't aware of a tick attachment, but cat scratch disease, so people know, you get scratched by a cat, and then you get a scratch that looks infected, it festers, and then often there's a lymphangitic streak, so a red streak going up to a lymph node, and then the lymph node gets swollen, and allegedly 9 times out of 10 the immune system deals with it even without antibiotics. I'm not sure that's still the case, that the immune system does that good a job in 9 people out of 10 that it takes care of this bug. I think it's more likely that even though they get better, they still have Bartonella in their system, and then they are prone to problems down the line. Like Thomas, by the way, that may have been the case with Thomas, who probably had Bartonella in his system. And anyway, also cat bites can do it. But there's a lot of Bartonella out there. The interesting thing is how many people don't get sick from it. And, and I think those people have the right genetics, and that they don't have tendency towards autoimmune problems. And God bless them. Unfortunately, so far, it's really hard to buy new grandparents, and we're stuck with the genes we have.
We're definitely stuck with them. And so sometimes when you test the tick, like if you pull the tick off successfully and you send it off to one of the different tick reporting groups, and I know Tick Report at Amherst, Mass. Says that they never find Bartonella in the tick or on the tick. Like it's never positive. So if you check that box, it's never positive. And I always find that amazing. What are your thoughts on that? I know I just threw that one out there.
Well, my best friend, I used to live in Massachusetts, right? And my best friend's in Massachusetts, and he had that same experience. He was actually told that they never see Babesia or Bartonella. And I'm like, well, they're doing a really, really lousy job. I mean, there are studies where they collect ticks and analyze them in places like Massachusetts, and they're there. The lab just is incompetent, quite frankly. I'm going to put in a plug for a lab. It's a nonprofit. It's a lab here in Colorado in Fort Collins. Go to a website, technology.org, and
Okay.
for very little money, they do a really good job of analyzing ticks. Any kind of tick you want, they'll analyze it. They do a much better job than these state labs do, or even big labs like IGeneX. I see better results. at technology.org.
Okay, great. Thanks for that link. I will make sure to put it into the recap with the slide. All right, so this is your last question. What are your thoughts on SOT?
On what?
On SOT?
Oh, wow, it's a really good question. Answers, I do not have a lot of clinical experience with it, and I have heard positives and negatives, but I'm not a good one to ask because I don't have that much clinical experience. I have one patient who did really well, but it wasn't sustained. I
Okay.
mean, when he came to me, he had basically totally relapsed. And and I can tell you what seemed to trigger his relapses was mold exposure. So, it's really interesting, what they're doing, and I'm open to hearing more.
Justin, what's your favorite tick spray? Do you do the chemically one, or do you prefer the natural, if you can apply it enough times?
Yeah. My youngest daughter, she lived in Pittsburgh, and they used to go camping and around there. And she would drench every family member in the nature pill stuff, and they still had ticks on them. I'm not crazy about putting DDT on us at this point, and not only that, but I'm been told that you need higher and higher concentrations for it to work now. So I think the best thing to do is to soak your clothes in permethrin,
Yeah.
and then to be careful and do tick checks every day. I mean, thank God I live in Colorado, quite frankly. My adult life was mainly in Massachusetts, where I got Lyme. My 3 daughters got Lyme. My ex-wife got Lyme. It's scary. It's scary out there. And there are things you can do to protect yourself, but you got to be so careful.
So careful. So with that, I wanted to ask that last question as I send everybody out on Sunday. And, it's good to put your feet on the ground, but we want to be, and get some grounding in us and all that, breathing some air without smoke, hopefully. But we want to be really cognizant of covering ourselves with at least something to try. And but that tick check at the end, I make everybody take their clothes off and put their clothes in the hamper, and then I put it in the dryer and burn that suckers as fast as I can, and then we do a whole tick check. No one's shy anymore about these tick checks after what we've been through. And the permethrin, you can order in sort of large bottles, by the way. The little small bottles will cost you a fortune, but you can get pretty big ones and wash your clothes in them, and it can be an easier process. So get out there, enjoy your summer, but please be careful, and tell all your friends about ticks, and just talk about it. Be the tick person, talk about them. It's the best way to keep educating and keeping it part of the conversation. Thank you so much, Dr. AKinderlehrer. It's been a wonderful learning experience, and you've answered a lot of questions at the end. And thank you for taking time of your busy schedule, and especially on a Sunday. We really appreciate it. And it's been a real honor and a privilege to meet you. I was so excited when you emailed me back. I was like, yay! Everybody in the house knew. So thank you very much, and have a great day.
Thank you, Gabriella.